Okay, so at the start of the Summer Institute, Gerd spoke a lot about risk and uncertainty and distinguishing situations that are involving decisions under risk and decisions under uncertainty. And so I think for the last few days, you've been really focusing on the decisions under uncertainty. And today I'm going to bring you back a bit along the other side and talk about decisions under risk. I am part of the Harding Center for Risk Literacy, which is almost now about to celebrate its 10th year anniversary. We were established as part of the ABC group here under the direction of Gerd Gigerenzer, and we're still here at the Institute for at least another 1.5 years. Now, just to give some background on the Harding Center, we actually came about because of a very generous donation by an investment banker, David Harding, who was very impressed reading Gerd's books on communicating risks, felt that he had made sufficient amount of money based on people's misunderstanding of financial risks, and decided that maybe this is a way to give back. So for obvious reasons, we haven't really looked so much into financial risks, and a lot of the work that we have done is focused in the area of health. But I hope that some of the things that we talk about today, you might be able to take back to your own fields and think about how you might apply some of these principles in your own work. Also, I think the talk by Ralph Hertwig last week also distinguished between decisions involving description and experience, so this kind of distinction. And what I'll be talking about here are really those in terms of description, but what I want us to think about is actually how we can describe risk information when we do have it available, because there are many different ways that we can present information that can be more or less transparent, and we'll talk about that today. So to give you an overview of the talk, I basically want to convince you that statistical illiteracy is a collective problem. What I want to share is that many doctors, politicians, healthcare providers, and of course the general public have trouble understanding health statistics. Okay? And I'll give examples done from a number of studies with the general public, but also with health professionals, to show that it's not just a problem that affects certain kinds of people. This is a problem that's kind of systemic. And it should make us think actually about how we represent information to help people understand. The good news is, otherwise why would I be here, is that statistical thinking can be improved with transparent representations. I'm going to talk about a number of different statistical formats and how they have been used to mislead or are just not comprehensible, and then talk about some strategies that we can use to actually help statistics be more understandable for the public. Now, to really kind of send this message home, I think one of the probably most widely used examples of the implications of poor statistical communication on decision-making in health is the contraceptive pill scare that was in 1995. This is the cover of the Sunday Times magazine in response to a release from a study saying that compared to the second-generation contraceptive pill, the third-generation contraceptive pill increased the risk of venous thromboembolism by 100%. Right, so it doubled the risk of essentially getting blood clots. And this is the kind of communication you saw following this kind of information. Now let's look at the impact or potential impact of this kind of communication. Here is a graph showing the abortion rate in England and Wales in the 5 years prior to this announcement and the 5 years following this announcement. And what you can see, the red line here, is roughly around the time that this announcement was made. And again, it was an increase in venous thromboembolism by 100%. As you can see in the 5 years prior to this announcement, the abortion rate in England and Wales tended to be on a steady decrease. Following this announcement, in the 5 years following, it's estimated that an additional approximately 13,000 additional abortions were performed in the years following this announcement, as many women decided to stop taking the contraceptive pill. Let's look at this statement again. The official announcement was that the contraceptive pill doubles the risk of venous thromboembolism. We could express the same risk in the following way. These are absolute numbers. We can show that the contraceptive pill increases the risk of venous thromboembolism from 1 in 7,000 women to 2 in every 7,000 women. So a difference from 1 to 2 is a doubling of the risk, or a 100% increase. But perhaps if we presented it in the bottom format, it may not have sparked such an outcry or such a change in behavior with many women. Ironically, the risks of getting a DVT or deep vein thrombosis from pregnancy or from the actual abortion procedure is higher than the risk of getting it with a contraceptive pill. So as a result of this communication, many people actually increased their risk by going off the pill in the terms of unwanted pregnancies and abortions. So, yeah?
Just looking at the graph, it seems that the trend had already started a few months before the announcement. And assuming that this announcement caused the rise, it would take a couple of months for people to start the abortion process. So are you suggesting causality here? So what is...
I don't think, I mean, these are also estimates. So, I mean, of course not. I mean, this at the bottom here is very small fluctuation, and we'd expect throughout that there would be small fluctuations. What this graph basically shows is that a very convenient increase in the abortion rate after this announcement. We can't say that this is exactly the cause of the increase, but one can say it's kind of a remarkable increase at a very specific or convenient time given the announcement. No? Sure. Okay, so what is the results or the risks of poor communication? In the general population, I mean, there's vast amounts of research showing that people fear the wrong things. I think it's very clear that people have certain phobias of things that are less likely to kill them than others. I think one of my favorite examples is this. It's actually an artwork that was commissioned by the Wellcome Trust for an exhibit in a London gallery talking about death. And you don't need to read all the bubbles, but basically the size of the bubble indicates different causes of death over the last 20th century. Obviously, these are very, very generous estimates. And what you can see in the big bubbles here are those that are most likely to cause death over the 20th century. These are things like non-communicable diseases like diabetes, cardiovascular disease, infectious disease, cancer, and to some extent war or other humanitarian causes. Okay, and we think with this in perspective, some of those risks that people really fear are actually really, really insignificant when you look at the causes of death from other aspects. This is from air crashes, and comparing this to road traffic accidents. And typically people fear the things that aren't actually going to cause them, or aren't likely to cause them so much harm. And things like non-communicable diseases and cancers and infectious diseases, these are things that tend to kill people, a lot of people, but over maybe a shorter amount of time. And some of these things like car accidents and air traffic accidents tend to kill people, a lot of people at once. Tends to instill some fear, and then people tend to fear these risks as opposed to those that are actually going to cause them more harm over the longer term. Also things like natural disasters. The funny thing about air crashes and road traffic accidents, for those people who do fear flying, the risk of actually something bad happening as a result of some kind of air travel, the most of that risk is already overcome just from the drive to the airport. So if you make it to the airport, the riskiest part of your travel is actually already. And just because I'm Australian, everyone always tells me about how many dangerous animals are in Australia. Really, you have other things to worry about. Obviously, this is worldwide, so I can't say how Australia-specific it is. But I think whenever I've looked into statistics, I think your chances of dying from an animal-related accident is actually very low, even in Australia. The second risk factor is that statistical information is difficult to understand, as we saw in the first example, but also especially when considering people's numerical competencies. And so as I hinted at the start, there are multiple ways that you can communicate statistics that are more or less transparent and more or less easy to understand. And I'm going to show you a couple of more examples similar to the one I showed you at the start with the pill. The other thing to think about when we're communicating statistical information to the public is actually what are their numerical capabilities generally. So how well can people actually deal with numerical information? So what I'm going to do is I'm going to present to you with a couple of questions, and I want you to guess for me the proportion of German and US participants from representative samples in each country who are able to get these items correct. Okay? So the first one, imagine that we flip a fair coin 1,000 times. What is your best guess about how many times the coin will come up heads in 1,000 flips? So what is the correct answer here? It's a basic probability. 500? Now, what proportion of the US public do you think actually could get this correct? What percentage? Take a guess. 60? Already starting so low. Germany? Okay, so 60% or higher. You're a little bit harsh, but about 73% of people got this very basic question correct. So 3/4. There's still 1/4 of participants in each country who can't actually provide the correct response. Let's look at another one. In a lottery, the chance of winning a $10 prize is 1%. What is your best guess about how many people win a $10 prize if 1,000 people each buy a single ticket for the lottery? So this is really basically turning a percentage into a frequency. Okay. How many people do you think got this correct? And let's start with Germany this time. 73? Less? And do you? 60? 62. And in the US? 40? Okay. This was done like quite some time ago, so any current views about the US? Yeah. 68% in Germany and 58% in the US. Okay, so just over 2/3 of German participants and just over half of US participants. And think about this. This is mainly just a very simple skill that we learned very early in our education, transferring a percentage into a frequency estimate. Now let's look at the converse. So we have another kind of lottery, a sweepstakes, and the chance of winning a car with this is 1 in 1,000. What percentage of tickets from the Daily Times sweepstakes wins a car? What percentage? So again, this is going the other way, turning a frequency into a percentage. So how do you think the Germans did? 58? 58? In the US? 48. 48, okay. So less than half of German participants and 1/4 of US participants got this item correct. Okay? If you think about it, these are very basic questions that we should learn very early in our education. And these are with representative samples from both countries. So if we're thinking about how to communicate statistics to the public, we really have to keep this in mind, that they're very basic numerical competencies. And if we use very complicated statistics, then this can very easily mislead or confuse people. Now, if I was to tell you that we asked doctors these 3 questions, how well do you think they performed? They did better. That's kind of a relief, but still only 72% of physicians got all 3 questions correct. Okay, so about 1/4 of physicians got at least one of these items wrong. Okay, and they deal with health statistics or statistics on a daily basis. So this is kind of concerning if not only the general public, but also health professionals who face more statistical information also have difficulty with these kinds of items. And then the third point, not surprisingly, people vastly overestimate the benefits of medical intervention. So if we think how we constantly hear information about health interventions being communicated, we should have some good idea at least about the size of the effect of different medical interventions. So this is, again, another study on representative samples from 9 European countries. And they were asked how many fewer people die from prostate cancer or breast cancer in a screening versus a non-screening group. So the men were asked about prostate cancer screening and the women were asked about mammography screening. Which country do you think did the best at estimating? Russia? Netherlands. Mm-hmm. Okay, so the true answer for this is 0 in 1,000 for prostate cancer screening, so no lives are saved as a result of prostate cancer screening. For mammography, the answer is 1 in 1,000 women. What you see by the dominance of the red bars here is the proportion of people, or the percentage of people in each country that overestimated the magnitude of the benefit. And it's not even just by a little bit, by a few numbers, but really by a factor of 10, 100 or more. Okay? The yellow bars are those that gave an estimate that was rather realistic. And someone guessed Russia as being the best of the bunch. But this may not necessarily be that they were better informed, but maybe less misinformed. So if they don't receive so much information about cancer screening, maybe they're actually better able to judge a magnitude. For breast cancer screening, there are quite a proportion of women who gave an answer of about 200 in 1,000 lives are saved as a result of mammography screening. And you can see maybe where they get this kind of confusion, because the benefits of mammography screening are typically communicated in a relative risk reduction of 20%. So 20% reduction in mortality. And it's possible that women confuse this with actually 200 out of 1,000 women lives saved as a result of screening. Now, it's not just the public, physicians. There are also problems that we mentioned just before about numerical capabilities. But throughout the talk, I'll also show examples when how physicians are misled by statistics. So it's not just about communicating to the public, but also ensuring that our health professionals can understand. Yeah?
Question, because you're presenting the results of before as misinformation, but could it also be that it reflects the subjective value that people attach to screening? Because maybe they don't know the exact number, but it's like sort of an hopeful estimate, like this is what they think screening is worth.
Okay. Can you rephrase that? Sorry.
Yeah. So my thing is, or that many people may not have known the exact number.
Mm-hmm.
So
Yeah.
so their answer reflects some sort of subjective estimate of how good screening is in general. That like more the opinion that they have about screening than actual misinformation.
You mean about any kind of screening test? Like just in general, I think screening is good and it should save X number of lives. I mean, it's possible. It also means that they're not informed, right? Yeah, of course. But this is also, particularly in the case of prostate cancer screening, mammography screening, which particularly more with mammography screening, this is actually offered by health insurances and health systems in many countries. If you are to participate in that, one would hope that you've actually been told some kind of information about how much benefit that actually offers. If you haven't, I think it doesn't matter. They still overestimate whether they've actually seen the information and misinterpreted it, or just not seen this information at all. Sure, I think there are some studies that look at people's perception of medical interventions, and you do tend to find that people just believe that if you have a new medical procedure or something, that it should be more effective than an old one, which is not actually the case. And I would suspect with screening, I mean, intuitively you think, okay, if we screen people and find cancer early, then obviously this is a good thing. And this obviously, I mean, what we know now, it doesn't actually match the evidence for some screening tests. But that's true, yeah. Second, physicians overestimate the certainty of medical tests, and this is problematic because often physicians are communicated statistics about how well medical tests perform, and they also tend to overestimate how good or how certain the results of those medical tests can be, and we'll show an example later on. And I think quite concerningly that even if we do have all relevant information available, physicians often fail to communicate it clearly. And there are many reasons for this that are beyond the health statistics, and this could be things like defensive medicine or conflicts of interest or other things. But I'll show you a study done by a colleague where physicians were provided with the correct evidence, and they chose to communicate it in less transparent formats to different kinds of patients. So there's risk factors at the general public level, also at the physician level, which we'll focus on today. So as I mentioned before, it's good. We know that statistical thinking can be improved with transparent representations. And I'm going to talk about 4 different statistical formats: single event probabilities, relative risks, which we've already talked about, but I'll discuss this a little bit further, 5-year survival rate in the context of cancer screening, and conditional probabilities, and talk about formats that we can actually use to improve people's comprehension and understanding of these statistics. So let's start with single event probabilities. What is wrong with single event probabilities? This is actually a study that was conducted based on an anecdote from a psychiatrist who was prescribing his patients Prozac and was very surprised at how alarmed some patients felt when he gave this statistic. This is related to the side effects from Prozac. Prozac is associated with 30 to 50% chance of developing sexual problems such as impotence. Okay? What does this actually mean, though? Does it mean that 30 to 50% of patients who take Prozac will have sexual problems? Does it mean that patients taking the drug will have a problem in 30 to 50% of their sexual encounters? Does it mean that the sexual intercourses of the patient taking the drug will be 30 to 50% less enjoyable? Something else? What do you think? Any guess? The first one? Yeah? But you can see the problem with this statement, right? It could actually mean all of these things because it doesn't actually have anything about the reference class. Like, so to whom is this chance referring? As you said, the correct answer is the first one. But what you can see here, this is a study looking at students' interpretations and also elderly patients' interpretations of this statement. And while most students, but still only 3/4 of students, correctly identify the first statement, about only 1/3 of elderly adults were able to recognize that this is the correct interpretation. And this is then not surprising that when they were provided with this statement by the psychiatrist, that there may have been some more alarm depending on what interpretation they took from the statement. So the problem with the single event probabilities is that it's not very clear to what the probability refers to. And the very simple way to overcome that is just to make sure that you have the reference class clear. So to what does this 30 to 50% chance refer? Okay, here it's to 30 to 50% chance, 30 to 50% of patients who take Prozac will suffer sexual problems. Okay, and just this very simple addition to the statement can help people to better understand the probability. So relative risk we talked about with the pill scare, but we'll just go through another example just to make sure that we understand why it can be very problematic. So some of you may recall a couple of years ago, there was a release by the World Health Organization about eating processed meat. And the statement was basically eating about 50 grams of processed meat a day increased the chance of developing colorectal cancer by 18%. And this was very big news in Germany. Processed meat is quite a staple of the diet, so it was quite a concern when this information was available. And I think what was most problematic with this statement was that the media release was released well before the publication was made available. So even those people who actually wanted to understand the numbers had a lot of difficulty and had to wait quite some time for us to be able to get access to the numbers to find out how big this risk actually was. But also the WHO actually classified processed meat as carcinogenic to humans. And this was included in the same category as X-rays and tobacco smoking and asbestos. Okay, so this seems quite alarming, right? There's quite a big risk from processed meat. So again, let's look at the numbers. What does this 18% increase mean? Does it mean that it's an increase from 5 in 1,000 to 6? So 500 in 1,000 cases to 600 in 1,000 cases? Does it mean that it's the difference from 5 in 1,000 to 6 in 1,000 cases? From 0.05 to 0.06 in 1,000 cases? Sorry? Did someone say something? The three, well, that's true. Yes, the 3 of them are true. So 18% increase could apply to all of these statistics. But then it's problematic, right? How big is the actual risk? Now, the correct one is 5 in 1,000 to 6 in 1,000. And this means that the risk of a 6-year-old person being diagnosed with colorectal cancer within the next 10 years increases from about 5 in 1,000 to 6 in 1,000. So additional 1 in 1,000 cases. But you can see that by providing a relative risk, particularly without providing anything about the baseline risk, it's very difficult for people to actually know how big or small that risk actually is. And I just want to point out here, you can also see very clearly that this statement has the reference class. So we're talking about a 60-year-old person diagnosed with colorectal cancer in the next 10 years. So it's very clear what that risk refers to. So just so we understand how relative risks are calculated, let's assume that we have a new surgical procedure and we want to look at how it compares to, say, the standard treatment. Say we have 100 patients who receive a certain standard care, so the typical surgical treatment, and we test another 100 patients with our surgical treatment. We find in this study that the difference is about 1 in 100. So in the first case, in the standard care, 4 in 100 people die as a result of this treatment. In the comparison, it's 3 in 100. So in absolute numbers, this is quite easy to see, a difference of about 1 in 100 in terms of mortality. Now, how the relative risk is calculated, you compare the probability of the event in the group that's exposed with that in the group that's not exposed, and you come up with a relative risk, in this case, a relative risk decrease of about 25%. Okay, so a difference from 3 to 4 is a 25% reduction. So we also measure the complications of the treatment. The serious complications in the standard care is 1 in 100, whereas in the new treatment, it's actually 4 in 100. So again, in absolute numbers, we can compare. When we calculate the relative risk ratio, we see that there is an increase of about 300%. Okay, so a 25% decrease in mortality, but a 300% increase in the complications. Now, some of these formats are transparent and some are not. The non-transparent ones are the relative risks, because if we presented people with information using these statistics, it's very difficult to understand actually how big the reduction in mortality is, or how big the reduction increase in the complications is. With the transparent communication, we can actually see it. So it's a 1 in 100 life saved, but 3 in 100 people have more serious complications as a result of the surgery. What's concerning is when you get this kind of combination, which is called mismatched framing. So this is where people use a large number, the relative risk, to communicate something about the benefits, but a small number to communicate something about the harms. And sometimes even to the extent that they don't include any information about the harms, or they give a very selected view of the harm. So not even reporting about the comparison between the control and the new treatment group, but just looking at what happened in the treatment group. So when you communicate like this, how possibly can people interpret how good this intervention is? You can't compare it using numbers presented like this. And this is what you have seen, at least in the case of mammography screening, where health brochures have included information like the benefits in large numbers, the relative risk reduction, and either no information about the harms, or presenting the harms in small numbers. So I think one of the points I mentioned about physicians is that even when physicians have all the information available, it's not necessarily the case that they communicate it transparently to patients. And this is a study that was conducted by Wolfgang Geismeier and his colleagues, looking at how physicians would communicate the effectiveness of a drug to a group of patients where they thought that the drug would be safe and effective, and to a group of patients where they thought the drug would be not safe or effective. Now, ideally, this should not change. Irrespective of how you think the drug is going to perform for those patients, you should communicate the information in a way that is transparent and helps them to understand the magnitude of the benefits and harms, and give a balanced view of the benefits and harms. Now, they asked 142 physicians which of the following pieces of information would they communicate to the different types of patients. They could select up to 4. Now, the first 2 columns, they give you the percentage of patients in each group who experienced 1 benefit and 2 harms. The third column is the absolute risk change, so this is just the difference between the percentages. And in the fourth column, you have a relative risk change, which we've discussed, obviously, in the last slides. So they could choose up to 4 pieces of information. So in the scenario on the left, you see those, what the doctors decided to do, whether they thought the drug was safe and effective, and what they decided to present to patients whether they thought the drug was not safe or effective. And you can see that there's about 87 out of the 142 physicians who did provide identical information, so this is good. But you also see that there are a proportion of physicians who actually switched depending on who they were communicating to. And this is what you see in the second and the fifth bar. What you can see with the color coding is the kinds of information patterns that were found. So in the white bars at the bottom, these ones here, this is where the information was provided in a complete and transparent way. Okay, so this means that the patients got maybe balanced information about benefits and harms, and in a way that helped them to understand the magnitude of the benefits and the harms. The gray bars above this are those that provided complete but not transparent information, so they may have provided information about both benefits and harms, but they didn't provide it in a transparent way. The dashed lines are those that provided information that was basically not interpretable. So it was missing comparative information, so they might have only provided information about a treatment group, and maybe only information about benefits but no harms. And the top two are related to nudging, where you would imagine that you present information in a way where the benefits appear larger, for example, the relative risk change, or making the harms appear larger by using the relative risk to present the harms. And you can see for those physicians that that informed differentially, that these bars are very reflective of that kind of information. So if they thought it was not safe and effective, they were more likely to use formats that made the harms look larger, and vice versa. So this is then concerning, yeah?
I was going to ask if this is a bad thing, per se.
Yes.
I mean, there's many work about shared medical decision making, and there's a very large group of patients that actually don't really like the fact that they are involved in the decision and want the doctor to help them. Mm-hmm. So when I see this, they're involved in the decision, but the doctor is already instead of telling them what to do, sort of suggesting it. Would you say that is bad?
It depends. So one, you're assuming that all the patients are then in this category where they want the doctor to tell them what to do. Okay, and we have no information about the patients. We're not saying that the patient wants to know, just tell me what you think is best for me. But you're right, there are some patients who are very happy having the doctor tell them what to do. But, I mean, you talked about shared decision-making. The informed decision-making medicine is an ethical principle, right, where you're supposed to be able to provide information about the benefits and harms of interventions to patients in a way that they can understand them, okay? And yeah, some people don't want that, but for those that do, and we don't know what proportion, they were never told, those that wanted them to make the decision in this study, you should assume that providing patients in statistics in a way that they can understand, and that will help them to make their own personal decisions. You're also then assuming that the doctor knows the preferences of the patient, which he doesn't necessarily have. I mean, if a patient wants to ask the doctor, yes, tell me what to do, sure. But I think it's an assumption that this is actually what patients want. And many patients are quite happy to see the numbers and then discuss it with the doctor. That would be the ideal case. So I think, no, I don't think that this is a good thing. Yeah? I don't know. I don't see the microphone being handed over.
Yeah, here, but we don't have one on the others. Can you provide one?
Connecting it to the last question, I think one important parameter that we're not inserting in the question you asked is what the patient wants as an outcome of his or her treatment. To make it more specific, if I'm a woman in my 20s and I have not reproduced yet and I'm planning to marry, being presented with an option and I'm diagnosed with breast cancer or ovarian cancer, etc., I will make very different decision than a woman that is in her 60s, is married, she had children, etc., etc., etc. So I think that's an aspect and an element is very important in this conversation, because I understand, especially when we're talking about people of older generations, they want to be presented with an option that the doctor suggests as the good one, but it really depends on their circumstances.
And this doesn't prevent patients from making their own decisions based on the information. This is even kind of a step back. We're just saying, okay, if you present information to patients or to the public or even to doctors, at least present it in a way that helps them to understand it. And then any preference that you have, you can at least then weigh up the evidence in a way that you can understand and still make your own decision in line with your preferences. And most of the time, this informed decision-making principle is for cases where the medical establishment can't decide what is the best, in the best interest of patients. And this is related to many medical interventions. I'd say probably even the majority of interventions, because we just don't have a very clear-cut good intervention. And that does involve some trade-off between benefits and harms. Okay, the third statistic I want to talk about is 5-year survival rates. And here I'm really specifically talking about the context of cancer screening. So 5-year survival rates are a way to compare the effectiveness of different treatments. But here I want to talk about the problems with them when they refer to the outcomes for cancer screening. So in 2007, Rudy Giuliani made the following statement. So he had prostate cancer a number of years ago, and he says his chances of surviving prostate cancer in the United States was 82%. His chances of surviving prostate cancer in England was only 44%, which he then takes a stab at socialized medicine. Okay? This seems rather surprising, right? The US and the UK, I wouldn't imagine that their health outcomes were so different, but how do you get such a difference in the survival rate for prostate cancer between these two countries? So here's a graph looking at the the mortality and incidence rates in the US and the United Kingdom. The red line in each of the graphs is the mortality rate. The blue line is the incidence rate, so the number of people diagnosed with cancer. And then we have some more recent estimates about the survival rates in the yellow lines for each of the groups. But this is very recent. And they don't quite match the numbers that Rudy Giuliani mentioned, but I'm not sure exactly where he got those statistics from. But I want you to just have a look at the graph, and what do you find surprising if we're talking about survival rates for prostate cancer? Look at the mortality rates in each country over these years. What do you notice? Sorry?
It almost looks like maybe it's just a few, but it looks like they don't add up to 100.
So these are age standardized rates. So the number of cases per 1,000 people. So you would get for mortality about 20 in 100,000 people would die. Yeah. Sorry. Yeah.
It shows that the mortality rates are pretty similar.
Mm-hmm. Which is surprising if the survival rate was so different, right? So what else do you see that's different about these two graphs? Yeah.
The incidence rate is a lot lower in the UK.
Mm-hmm.
Which is probably why the percentage is higher.
Mm-hmm.
Because there's just like a fewer people who actually get it, and they, I don't know. So that's why the percentage is also gets skewed.
So more people seem to be getting or be diagnosed with a cancer in the US compared to the UK. Was there one more comment? Yeah.
That's out of 100,000 on the left side. Is that correct? If I look on the absolute numbers, it only goes from 0 to 200 out of 100,000.
Yes.
So I mean, effectively, it's the same in both.
Yeah.
Difference.
Yeah, I mean the incidence rate, yes, and actually with this peak actually continued. It was quite an increase around the early 1990s, and this is when the PSA test, which is the blood test to screen for prostate cancer, was becoming more widely available. And in the US, you found this really big peak. But while you see this big peak in the incidence rate, you actually don't see such a drop in the mortality rate between these groups. Okay, and the mortality rate between the countries actually is very similar. So what is actually going on here? So the problem with survival rates as they're communicated in relation to cancer screening is that it's subject to two biases that kind of makes the rates not comparable. So the first bias is the lead time bias. And I can explain it as follows. So let's assume that we have a group of men who, without screening, get diagnosed at the age of 67. Because they have symptoms, they go to the doctor, they get screened in, they get diagnosed at 67, and they die from whatever cause, whether it's prostate cancer or some other cause, at age 70. So their 5-year survival rate is 0. Okay? They only survive for 3 years after the diagnosis. Now assume you have exactly the same group of men. They're diagnosed with cancer because of screening at age 60. So by definition, cancer screening is intended to diagnose cancer at an earlier age or earlier point. So they get diagnosed at 60, but nevertheless also die at the age of 70. Here, their 5-year survival rate is 100%. But have they survived any longer as a result of screening? No. Okay, all this has done is to increase the lead time, so increase the amount of time that people know that they have cancer without necessarily making much of a difference in terms of the mortality. A second bias is the overdiagnosis bias. Excuse me. And we can explain it as follows. So assume without screening, in a group of men, there is 1,000 aggressive tumors. They're diagnosed as a result of screening. And 5 years later, of these 1,000 aggressive tumors, patients with aggressive tumors, 440 of those patients are still alive, and 560 of those patients have died. Here, the 5-year survival rate is 44%. Okay? Now imagine with screening, not only do you pick up the 1,000 aggressive tumors, as you did in the first case without screening, but in addition, you pick up an extra 2,000 of non-progressive or low-growing tumors. Okay, and this is, again, we would expect with cancer screening that they do pick up cancers in their earlier stages. The problem is with lots of screening tests is we actually can't differentiate between those tumors that are going to be very aggressive and likely to kill someone, and those that are non-progressive or very slow-growing. And with prostate cancer in particular, you have a very slow progression of the disease in most cases. Not all cases, but in most cases, it takes many, many years. And often, at least for some time, there were estimates that people were more likely to die from some other cause than the prostate cancer that they were diagnosed with, just because it takes so long. But in this group of patients, when we look at the people who are surviving after 5 years, we see that not only are the 440 patients alive that had the aggressive tumor, but we also have the 2,000 people who had the non-progressive tumor also being alive. And now because the diagnosed people are also in the denominator as well as the numerator, this inflates the survival rate. So in this group, we get some numbers that are very similar to what Rudy Giuliani had mentioned, that 81% of people survived for 5 years after diagnosis. So this is then problematic because it's, rather than looking at the mortality rates, which we did when we compared the England and UK, which were roughly about the same, the survival rate just basically inflates this statistic. And so for cancer screening, it's not really a good statistic to use. Now the problem, yeah?
When you're comparing screening with non-screening, are you assuming that no treatment takes place following screening?
No, okay. Treatment can take place, yeah.
So then, how can you differentiate the impact of screening and versus the impact of treatment on the survival rate?
What do you mean, like how many people die from the treatment itself, or?
The sooner you screen it, the sooner you would change your lifestyle, the sooner you would get certain preliminary treatments. So, so if the survival rate changes, is it because of the fact that they've been screened or because of the fact that they're getting treatment?
I'm not sure I exactly follow your question, but it's hard to tell, right? Because you don't know what's a result of the treatment. The point is if you have the same group of men, they still die at the same rate. So it's still the mortality rate doesn't change. You could actually find what you would hope to find is not only that they survive from the cancer, but they also survive from other causes for a longer period of time, and we don't actually see this. So you might find that, yes, they don't die from prostate cancer, but they die from something else within the same period. You can't show that treating them for prostate cancer actually showed some survival benefit.
So, in the previous graph, if you could just so you're assuming that both cancers start at a certain point in time and they die at 70, so the screening doesn't affect the survival rate. Is that right?
Screening doesn't. The screening does affect the survival rate.
I know. I mean, I'm sorry. The time of the how long they actually, how long when they die. So there's no treatment happening here.
No, there is treatment. They could be treated for. The point is, we're assuming that. We would hope to assume that by screening, you do get earlier treatment that does enhance survival, right? That's in an ideal case, or at least in some ways improves quality of life, right? So we should see that there is a reduction in mortality over a certain period of time. Here in this group, if this group had been screened, they would have found it earlier. So they're still living with the cancer the same amount of time. We're assuming the same. They just would have lived longer knowing that they have it. But they die at exactly the same time for whatever reason. It could be from the prostate cancer. It could be from some other cause.
I guess my question is that a realistic assumption that somebody who learns about their cancer 10 years earlier would still die at the same time as someone who doesn't know?
So how this is typically tested is with randomized controlled trials, where you get a group of people who do not have cancer screening and a group of people who do have cancer screening. And by comparing the mortality rates across the groups, you can see, did screening actually enhance mortality in that particular group? So this is the best way, or the only way that we can actually tell whether there is a decrease in mortality. So in the screen group, you would expect that they treat. And the non-screen group, you also assume that if they've been diagnosed, that they also would be treated. But if there's no mortality difference in the groups at the end of, say, a 10-year period, you can't really say anything about the screening actually reducing mortality. What you could still say is that it actually increases 5-year survival rates because they know for a longer period of time. Yeah, I think there's a question here. Yeah.
I'm trying to understand. So the real problem that can come up with survival and mortality rates is what we intuitively understand as survival rates. Because if, like, the first time I heard survival terms, I was assuming that it meant the amount of people that survived having had the screening. Here, however, from what I am getting is that survival rates actually mean how many years, how much time you knew that you were living with a disease, which is completely different from mortality rates. How many people were saved actually by knowing earlier that they were having the disease.
So, yeah, I mean, whether you describe it in terms of mortality rates or survival rates, like the graph that I showed with the incidence of mortality, you could put at the flip side how many people actually survive. But that's not the metric. So it's a 5-year survival rate for cancer screening. For treatment, maybe this is also some of the confusion. For treatments, 5-year survival can be a very good metric for evaluating the effectiveness of treatment. So you have two people who have cancer, and you're comparing two different treatments, say, prostatectomy versus radiation therapy. If you look at the amount of time that people survive as a result of the point in time that they had the treatment, then you can compare which treatment is more or less effective. For cancer screening, it's not so clear-cut because you're just increasing the amount of time that a group is diagnosed because of the way that the statistic is calculated. Okay, so you're not really comparing like equally across the groups. With the treatment, the survival rate is calculated for people who only have the treatment. Okay, here it's slightly different. This is why I'm saying it's specific to cancer screening. But for medical treatments and trying to determine how effective they are, then 5-year survival rates can be can be used for determining which treatment is better. Yeah. I think there's, which one? Yeah?
So basically, is this specific for people who are like of age 60 or 67? Because suppose, for instance, if you're dealing with people who are diagnosed at 57 and 50, would that make a difference then? Basically, that people who were diagnosed at 57 would die earlier, but people who were diagnosed at 50 would still die at 70 or something like that? Because I'm wondering if the age has anything to do with the relationship between the lack of a relationship between screening and survival.
So you're just saying just if they're diagnosed younger, right?
Yeah,
but we
like
still look at whether they die at 70. The 5-year survival rate would show for both groups then that they survive 100%, but it doesn't say anything about when they actually die. And you still have the group that was screened being diagnosed for much, much longer.
All right.
Yeah, in these RCTs you mentioned earlier, did you also look at life quality or subjective well-being, depending on whether they are diagnosed at age 60 or not?
So these are just examples, so they're not based on any RCT, but we have examples for breast cancer screening, prostate cancer screening, cervical cancer screening. It depends what the studies look at. Not all of them look at this criteria, but this is also another valuable criteria to see whether quality of life improves. So you could be diagnosed with cancer without screening, but you just have a very terrible time of it for these however many years you're alive. But in a screening group, you might have some treatment that improves your quality of life for this time. And that would also be some way to determine the value of the screening test. Unfortunately, it's not often the case. It's not done in the RCTs, but there have been some studies comparing outcomes for, say, different treatments for, in this case, prostate cancer, and you find that the effects of treatment can actually be quite bad. So you have impotence and urinary incontinence and lots of things, and they're kind of comparable amongst the treatments. The problem then is that if you're diagnosed earlier, you're more inclined to treat it earlier, which means you're more likely to then have longer times with these bad side effects from the treatment. So this is also something that, of course, that you can compare. And this is something that people often refer to as like overtreatment. So if you can't necessarily show a mortality benefit, or if there's no metrics on quality of life, you could actually infer that people who were screened and treated were done so unnecessarily, because it was not necessarily the case that their life was prolonged. It just means that the life they had was kind of worse than if they had just left it alone. The problem, I mean, this is very difficult with cancer screening. I also think because it's not very intuitive, that it's maybe actually more harm than good, or of only small benefit. Because we assume that it should be a good thing. But yeah, there's different ways to evaluate it, but in terms of mortality is a very clear indicator, not just from us, but also from how medical treatments are evaluated. And quality of life, so far, a lot of the evidence suggests that maybe it actually harms more by decreasing quality of life because of the treatments without the benefit of survival. Yeah. Do you mind if I continue and we can talk about more after? Physicians then confused also with 5-year survival rates? I'd say yes. There's a study looking at primary care physicians in the US, and they were asked to indicate which of the following statements indicated that a cancer screening test saved lives. The good thing is that 81% agreed that if mortality rates were lower among screened persons, then this would indicate that the cancer screening test did save lives. 76% of physicians said that if the screen detected cancers had better 5-year survival rates, then this would indicate that the screening test saved lives, which we've just discussed here, how that might not actually be the case. Concerningly, about half of physicians stated that if more cancers are detected in a screened population, then this would indicate that cancer screening saved lives. And if we think back to the incidence and mortality rates between the US and the UK, we can see that this is obviously not the case. Just because more people are diagnosed doesn't have anything to do necessarily with mortality. Further, when information about a cancer screening test was communicated in terms of survival rates, 83% of physicians judged the mortality benefit to be large, whereas if the same information was provided in mortality rates, only 28 of physicians. So this is the same statistic, and I have another example here about whether physicians would recommend a screening test depending on whether it was communicated with survival rates. a difference of 68% 5-year survival to 99% 5-year survival, or mortality rates, a difference of 1.6 in 1,000 to 2 in 1,000, or the other way, 2 in 1,000 reduced to 1.6 in 1,000. And you can see that this actually does seem to affect how they think about the efficacy of the test. So more physicians in Germany and the US would recommend this screening test if it was communicated in survival rates, and fewer if it was communicated in mortality rates. So they're also misled by this statistic, which is not surprising. The final example I'll talk about is conditional probabilities. And I won't talk about this first part so much because I think Ralph had mentioned this in his talk. He talked about the difference between research claiming that man is an intuitive statistician and studies that looked at whether he is Bayesian or not. And I know he talked a lot about description and experience, but I'm going to focus on descriptive problems and look at how we can even present descriptive problems in ways that are even more transparent than others. So, assume we're trying to infer the probability that a 40-year-old woman who is pregnant has a child with Down syndrome, given that they test positive on what's called the neck fold test. And I think this is the test where they measure the width of the neck in an ultrasound. So typically, how this information is communicated is as follows. So first we get information about the base rate of the test. What is the probability that a woman is pregnant with a child who has Down syndrome? And this is 0.15%. Then we get some information about the hit rate of the test, or the true positive rate. So what is the probability that a woman with a Down syndrome baby will test positive on the neck fold test? And this is 80%. And now what is the false alarm rate, or false positive rate? The probability that a woman without a Down syndrome baby tests positive on the neck fold test is 8%. Okay? Anyone want to hazard a guess about what the probability is that the woman has a baby with Down syndrome, given that she tested positive? 4%. 4%? Any other guesses? Above or below 50%? Below? Okay, good. Okay, so we can calculate a correct solution. It's about 1.47%, so actually quite small probability that the baby actually has Down syndrome. Now, not surprisingly, when information is presented in this format, people are not very good at calculating the correct solution. And on problems like this, about 16% of people get the correct answer to these kinds of problems. And the dominant explanation at the time was that people fundamentally neglect to consider the base rate. Often they make an error of communicating the true positive rate, so confusing this with and saying that it's 80% probability. And so fundamentally from these problems, the conclusion was that people are very poor at poor Bayesians. And Gerd and Ulrich Hofrager had a look at these problems and thought, actually, maybe we need to think a little bit more about how this information is communicated and why it might actually be very difficult for people to interpret. And if we think about it, probabilities are actually very recent statistical format. And their idea was to actually take an evolutionary perspective, think how might people actually acquire the information about joint events, and how might this actually improve how people can calculate the correct solution. So what they did is they looked at a format that was mathematically equivalent, but not necessarily computationally equivalent. So presenting the same information as follows. So here we have information about the base rate. So 15 in every 10,000 women are pregnant with a child who has Down syndrome. So this is the 0.15% we saw earlier. The true positive rate is now a joint frequency. So of those 15 who have a baby with Down syndrome, 12 of them will test positive on the neck fold test. And the false alarm rate. So of those 9,985 women without who are pregnant without a child who has Down syndrome, 799 of these got a positive test. Okay, this is the 8% probability that we saw earlier. Now, if you communicate it in this way, the calculation is much easier. And not surprisingly, when you present problems in this way, at least up to 46% in the same study of participants could correctly calculate the solution. Okay? Because by providing the joint frequencies, you can actually ignore the information about the base rate. So you don't even have to look at this row here. You just have to compare the number of people who test positive and those that were true positives. Okay? And it makes the calculation much simpler. Recently, we conducted a meta-analysis looking at a whole range of studies who've looked at this kind of effect. There were lots of theoretical debates about what this actually means. But basically, we found that this effect is robust. And it's maintained across a variety of different moderators. So these are different ways of presenting the information with generally the same structure. We find also that performance is enhanced for not only lay people, but also experts. So a lot of this research has been done looking at medical experts as well, as children and older adults, as well as university students. So even children can solve problems when they're presented as natural frequencies. And that performance on these problems is generally boosted with visual aids. So when you provide people with a visual to sort of demonstrate the structure of the problem, they tend to do much better when calculating the correct solution. The good thing about natural frequencies, though, is you can also train people to use natural frequencies. And this is just one of a number of studies that have looked at training professionals, particularly if you think about how information is represented about medical tests, it is in terms of conditional probabilities. So how can you help people take that information and convert it into a format that they actually understand? And when you teach people to convert conditional probabilities into natural frequency formats, you can actually vastly improve how they perform on these kinds of problems. So this is taken from a study looking at gynecologists and how they estimated the positive predictive value of a mammography screening test. And you can see with the red line, it's closest to the best estimate. And before training, most people overestimated the positive predictive value, but when you actually train them to convert it into natural frequencies, they did much better at being able to calculate the correct value. So just to conclude, just talk about a few insights. So now what we know about how to prevent statistics to facilitate understanding. I'll talk about one thing that we work on at the Harding Center is actually formats for communicating outcomes of health interventions in the most transparent way that we know how. So this is what we call a fact box on the benefits and harms for the early detection of breast cancer with mammography screening. What you can see here, so these are the results of RCTs. And you see a group of women who do not have the screening compared to a group of women who do have the screening. You note that the reference class is very clear, so it's women aged 50 years and older who have either participated or not participated for a period of about 11 years. You can see equal weight is given to the benefits and harms, and the benefits and harms are presented on the same scale. So it's easy to compare. There's 1 in 1,000 lives are saved as a result of mammography screening, but we can also see that this may lead to 100 in 1,000 women having false positives, and an estimated about 5 in 1,000 women being overtreated as a result of cancer screening. So you can also not only compare the numbers between the two groups, but also within the group you can compare the benefits and harms using the same scale. And we also talk about mortality rates here rather than survival rates, so everything is presented as mortality rates from breast cancer or other types of cancer. We also work on other kinds of formats, so this is the same information presented in what's known as an icon array. And this is kind of a format to help people build on their visual competencies. So rather than looking and comparing the numbers, people can actually just visually compare the proportions who experience outcomes in either of these two groups. The Harding Center also works with health organizations and health insurances. So we've had a project with the AOK, which is one of the major health insurances in Germany. We've also worked with Helsana, which is one of the major health insurers in Switzerland, who have seen our work and actually tried to communicate the results of their health interventions much more transparently. Also, there are some colleagues from APC who work at teaching children about risks very early in their education. And there's also been a recent study in Uganda where a group of researchers tried to communicate to children how to evaluate the effects of medical interventions, and not just in terms of numbers, but how to determine whether, how to test whether a claim is actually true. And they've had a lot of success in getting children to actually better estimate the outcomes of medical interventions. And I think that's a good point to conclude. So this is a couple of quotes by Gerd, but quoted by Ralph Hertwig and Till Gruanyanov. Statistical illiteracy, if not addressed, leaves citizens, patients, and doctors vulnerable to techniques that deliberately and insidiously exploit limited statistical literacy in order to convince the audience that they are at high risk of illness, and ultimately renders the ideals of informed and shared decision-making unattainable. So if anything from this talk, I think what would be good if you took away how we represent information matters. Okay, so it's not even, if we are looking at problems and describing outcomes in terms of risk, there are still multiple ways that you can present statistics that can be more or less transparent. And we should really think about how we present the information and the impact that it have on people's competencies. Thank you.